My name is Daniel Albo. I'm the chair of surgery for the University of Texas, Rio Grande Valley School of Medicine.
Dr. Albo, we're so pleased to see you today for this very special interview. I'd like to talk to you about the development of the surgical oncology program, because as I understand it, there's something special happening here, which we in South Texas, anything south of San Antonio, we've never had anything like this before. The degree of specialization that you and your colleagues are bringing. Can you talk about that?
Yes, our pleasure. So the University of Texas recognized early on, a problem that everybody kind of knew about, that there is a very high incidence and prevalence of cancer and complex cancer in the Rio Grande Valley in South Texas. And in particularly GI malignancies, liver, pancreas, foregut, colorectal. There is a very high incidence of these malignancies. And in the liver and pancreas world, this requires a very comprehensive surgical oncology management of these tumors to have the maximal beneficial effect of the treatments. They are part of a multidisciplinary care package that also involves care by medical oncologists and radiation oncologists. So think about developing an anti-protective cocoon around cancer patients with multiple components providing essential elements of service. The biggest gap in the valley by far was the surgical oncology part of it. As a matter of fact, when I was recruited here about 2 years ago, I believe I became the first complex surgical oncology trained by surgical oncology programs to come into South Texas. We've since been able to recruit Dr. Jim Cruz, who is also a complex surgical oncologist, a so-trained, fellowship-trained surgeon with specialty training in HPV surgery, hepatopancreatic biliary surgery, for short, liver and pancreas tumor management as a surgeon. And so the program has evolved now to a full comprehensive service coverage for all complex surgical oncology. And in the HPV arena, it now encompasses all of the most modern treatment modalities, from advanced complex surgical resective therapies. Think about removing tumors from liver and pancreas. These are complicated organs with a lot of complex vasculatures in difficult environments to operate on. And it requires a very specialized multidisciplinary team around each one of these patients, from surgeons to specialized nurses, advanced practice providers, and nutritionists, in hospitals with equipment and instrumentations that are state-of-the-art to keep these patients alive through the process of care and to thrive afterwards. It requires surgical intensive care unit environments. All of these have to be woven around these patients. At the core of it is a surgical oncologist performing the surgical therapies on these patients. For liver and pancreas tumors, this involves having access to more than one treatment modality. Resective therapy remains the gold standard. At times, either because the tumor is too extensive, is in locations where it cannot be removed, or it is in a location that can be removed, but the patient is too frail to undergo a massive liver resection or pancreas resection, then that's when these other forms of therapy come into play. They're called ablation therapies, and the best I can describe it is to destroy the tumor in place with minimal effect on the surrounding tissues and organs, so you can kill off a cancer without having to remove an entire organ or a large portion of an organ in an effort to preserve function and health after the procedures. The most advanced form of ablation therapy is now considered what's called microwave ablation. Microwave ablation works in a similar way that your microwave ovens work in your household. It is by application of microwave energy into a target to destroy it by intense heat application. The technology has evolved to a form that now can be delivered with a high level of precision in very controlled target environments, minimizing the damage of structures around it. It requires not just the microwave ablation equipment, There is only one of them available in South Texas, and it is currently located at Valley Baptist Medical Center, where we perform these procedures. It also requires very advanced intraoperative imaging modalities, and something in particular that is called a three-dimensional intraoperative ultrasound equipment. Think about the way dolphins see underwater in the dark, and you get an idea how this type of imaging modality works. And then to make it even more complex and more exciting from our perspective, these two machines, equipments, need to crosstalk to maximize the acquisition of the target, say in your liver or your pancreas or other organs, with an extraordinary level of precision, so you don't hit structures that you want to hit, and achieving a complete tumor kill with minimal destruction of surrounding tissues and organs and structures that are critical. And so this uses virtual reality blended models into these modern images. Think about think about a fighter pilot when they use these fancy helmets, how they see the actual targets, but also these coordinates all the way around it, and the precise trajectory to deploy their instruments, so you can avoid hitting things that you don't want to hit, and you make sure that you hit what you do want to hit and eliminate the tumor without destroying other things around it. This is a very advanced technology. It is actually rather expensive, and it is available in only 4 places in all of Texas, as it turns out, and very few other places outside of Texas. It is considered the most advanced technology for selective targeting of solid tumors in certainly the liver and pancreas, but also is applicable to other potential tumor site and applications.
And we have that here?
Yes, sir, we do. We've had it for a few months now. It requires a combination of expertise and training, certainly from the surgeon deploying these concepts, but also from the entire operating teams. This requires a complete team-based approach. We're blessed with an actual beautiful, wonderful team right here in this hospital, and it's available to everyone.
And we should tell the viewers which hospital this is.
This is Valley Baptist Hospital in Harlingen.
Mm-hmm. So where did you learn about this equipment, and how did you go about getting it? I know you're very much a specialist and highly regarded in this field, but you say there's not many such machines in Texas and elsewhere.
Yes, sir.
How did you learn about it?
So my interest in this harks back to my training days at Anderson, at the Anderson Cancer Center in Houston, in Texas. And there, the early versions of ablation equipment were being pioneered. And so the ablation technology has evolved from very crude, rudimentary early versions of it, and I have done just about all of them that I'm about to describe you. Initially was the injection of toxic substances in tumors. Alcohol ablation was one of the, ethanol ablation was one of the initial versions of that. It's very imprecise, and it has a significant amount of side effects. Then we move on to using cryoablation therapies, and some people still use them, where you kill by intense cold application. Problem is that is almost impossible to target intraoperatively precisely, because the ice as it forms interferes with the propagation of ultrasound imaging waves, and then you become blinded to the target acquisition. So, and it also makes patients sicker. There is something called a cryo syndrome that can be quite severe. Then it evolved into heat applications, and the technology that still a lot of people use nowadays, most centers are using nowadays, and it's called radiofrequency ablation, which is basically a localized electrical application that chars tissues on contact. It has some significant limitations in terms of how it works. The charring impedes the conduction of the energy, and there is areas of tumor that may not be completely ablated and destroyed, and therefore they persist. Also, because electricity tends to travel downstream from high resistant to low resistant areas, what's called high to low impedance transfer. Anything with a lot of water content, like a major blood vessel, would dissipate that energy, creating what's called a heat sink effect, which can lead to potentially lead to tumor, viable tumor left behind around the envelope of blood vessels, and therefore potential higher recurrence rates. So when you enter microwave ablation now into the equation, the way this technology works, it's just by making molecules vibrate, and the vibration produces friction, and the friction produces heat, and the heat kills the area. Virtually all molecules within the kill zone of the equipment radius will die, and so it's a much more homogeneous destruction of tumor with very, very circumscribed perimeter, so it becomes very, very accurate. It's also faster application, so means patients are less time under anesthesia, and the recovery tends to accelerate when you abbreviate the times of surgery. It can be deployed by percutaneous techniques without cutting somebody open. It can be deployed by traditional open surgery techniques for certain difficult to reach tumors, and it can also be deployed using minimal invasive surgical approaches like laparoscopic surgery or robotic surgery. In our group, we have specialty providers that not only are specialized in liver surgery, but also have high degree of expertise in minimal invasive surgical concepts. So we have blended all these approaches, and we use minimal invasive surgical techniques to deploy these antennas, as they're called, these probes, into the tumors for destruction by microwave application, guided by these modern ultrasound and virtual reality blended platforms of targeting.
So when you were hired, when the medical school approached you and said, look, we'd like to start a more specialized program in this field a few years ago, they must have crunched the numbers and seen just how bad a situation everything was down here.
Yes, sir.
And you were told that when you came in, that this is an area we just don't do well at all.
Yes.
Are you able now, I know it's only been a few years and this new equipment's just come in, are you able to look at the statistics and say we had X number of people dying before with these tumors, and now there's been a reduction, or is that not sort of quantifiable because the population's growing so much?
Yeah, this is a great question, and it almost begs the question, what were you thinking by tackling on something like that? You see, we consider ourselves purpose-driven people. It is that purpose that actually gravitated us towards here. The medical school has recognized the need to measure that impact, but not just for measuring the impact's sake, but to better understand the healthcare needs of an entire region. And it has created an entire new department, the Population Health Sciences Department, that one of the Valley native and most incredible success physician stories, Dr. Leo Vela, is now taking on a leadership role in it. He's absolutely amazing. The Population Health Sciences aims to answer the questions exactly like you just asked. What are the healthcare gaps? What interventions can be deployed? What is the effect of these interventions they have on the actual health of people on the ground? And once you understand how all of these things dance together, well, how can you improve access into that? What are the barriers and facilitators that are holding people from reaching the communities, as we talked earlier, into these more specialized centers where the care delivery can be provided to them? And so we have a very active, very vibrant research enterprise around this. Dr. Angela Cook was also recruited by the medical school to help lead the clinical outcomes research enterprise. And collectively, we work together. Our department is heavily engaged with both the Population Health Sciences and Dr. Cook's office in terms of beginning to formulate these questions and answer them with specific data. We are partnering with Valley Baptist and Cerner in terms of acquiring more sophisticated level data about the people in the valley, there's been a significant gap in our understanding of all these. As a matter of fact, there's a huge paucity of data, almost to the point of non-existent, about the exact kind of question that you're asking. What is the problem with a colorectal cancer screening? What is the percentage of the population that is getting access to potential life-saving colonoscopies? Breast cancer patients that are getting access to potential life-saving mammography. Where are the gaps? How do we develop these interventions, and what is the impact that it has? All of this is measurable. Collectively, we refer to it as health services research. But I almost chuckle when I say the word research on health services research, because it really is about understanding the needs, the gaps, and how to bridge them with the opportunities available, and then expand them to provide better care for more people at any given time.
And so Dr. Vella's on top of that. He's got a team in place to do those measurements.
So we have Dr. Vella on the population health sciences side. We have Dr. Cook overseeing the entire clinical outcomes enterprise, clinical research enterprise for the medical school. We have several actual members of our translation and research core faculty on the medical school level on the basic science and translational research sides of it. Think about disease as a continuum that zooms in and out from a little cell to an entire population of patients. And they're all interconnected. And all of these physicians and all of these researchers that we have at University of Texas Rio Grande Valley, we work together to bridge that continuum. UT-RGV just got a big grant from CPRIT, which is a very powerful research funding agency from the state of Texas that aims to develop these collaborative research enterprises. It was the first of its kind in South Texas. CPRIT had never funded before this a research enterprise in all of South Texas, and we're extremely excited about it. It's going live now, and I believe it's an over $6 million research grant to support this exact kind of program to answer the exact question that you just asked. That is the right question to ask her.
So, how bad were things before you got here? What was happening? There was just people were just not getting seen. Their illnesses were not being diagnosed fast enough. You were missed the hospitals. The medical community down here was missing those patients. How bad a situation did we have?
I think the Valley has had and still has terrific people caring for people, physicians, nurses, doing really God's work down here. The issue were the challenges facing, the discrepancy between the magnitude of the problem and the available people to care for that problem. And so I like to see them as opportunities. I'm an eternal optimist, perhaps. And there were significant opportunities in the Valley for developing these type of programs. Think of them as gaps in the services that could be provided in terms of type and overarching scale. And so this is where we come in. We aim to bridge those gaps and help provide value added to the healthcare enterprise for this part of the country.
And as a result of all this, as you were saying earlier in a different interview, you are saving patients and their families from having to go to be sent to MD Anderson, and the financial cost of that, perhaps some families prevented from actually traveling to Houston or San Antonio. That problem's being reduced now.
Yes, sir.
With your work.
Yes, sir. It's the collective work, I should emphasize, of a lot of people. Just today on my clinic, today in the morning, 5 such people are going to receive their care here in the Valley that otherwise would have to get that care elsewhere. Pancreas cancer, liver cancer, gastric cancer, sarcomas. Sarcomas are very rare tumors. And there is, inside of the world of complex surgical oncology, an even smaller number of providers with significant experience of managing them. There's very few programs that train in the high volume sarcoma centers, Anderson being one of them. By virtue of training, we have that. And so now we provide it here. And so just today, 5 of them don't have to leave this area. Dr. Cruz is doing the same things, and many of our other providers, a lot of them. Together with the work that happens in hospitals, this is not a one-man or woman enterprise. This requires a very sophisticated, total team-based effort. It takes a village really to care for one of these patients. And then it takes an enormous amount of coordination of care inside of that village to deliver it in a sequence where people don't fall through the cracks of care from beginning to end and back to the beginning. The line is a circle, and that circle is all encompassing for these patients.
Well, Dr. Albo, those are all the questions I had regarding your specialised work here in the Valley. Have I missed anything out? Is there anything else you'd like to add?
I think for today we probably gave you a couple food for thought, as we call it. We have some other extraordinary stories that are evolving here. The development of a really sophisticated trauma services, surgical intensivists, acute care surgery models, surgical endocrinology, minimally invasive surgery. There is a simulation center right next to us here. It is the first of its kind in all of South Texas, and it is a marvel. Think about the education of advanced pilots, marine aviator types, how they spend almost half of their time in advanced simulated platforms. Well, through the generosity of the Valley Baptist Legacy Foundation grant, we were able to build one right here for our trainees and our surgeons too. So we can take the technologies that keep on coming, and we safely transfer them into the realm of reality. That in and by itself, I believe, is probably one of the coolest stories that we're ever going to tell here in the Valley. But that's perhaps a different story for a different day.
Correct. We'll do that on another occasion. Dr. Albo, thank you so much for today's interview. We've learned a lot.
Well, thank you. Actually, what you're doing is very meaningful to us. It helps us spread the word about what is available to people. It requires an entire village, and you, sir, are an active member of that village.
Thank you very much indeed.
Thank you.